Okay, welcome back, everyone. Really excited to be here. Happy to bring this discussion to you all and to hear from you as well on communication and advocacy skills. And I called this a masterclass rather than a presentation because so far we've been doing a lot of didactic, more teaching style with this webinar series. And for the last session, I wanted to bring together some actual skills for you to wrap up everything that we've been talking about in the series. And I called it a master class because we, as care providers, as educators, and especially those of us who do birth work, direct services as doulas or lactation providers in our communities, we are told all the time, you're an advocate, you're an advocate. And I have found with teaching and mentoring lots and lots of birth workers all across the country that many of us have never been taught how to be an advocate or how to facilitate communication. And we're just told that we're an advocate and basically shoved out into the world without any mentorship as to what that actually means or how to do it. And so I've started to integrate some actual advocacy education and skills building into some of the trainings that I've been doing. And I found that people have really enjoyed it. It also equips us with the skills to be able to utilize our power, privilege, and position to uplift the most marginalized people in our communities and assure that those voices are brought to the spaces that they need to be at to assure systems level change. So we'll really dive into what advocacy means and how to do it. And we'll go into some case studies to actually put to practice some of the skills that we're going to be talking about today. And so, for those of you who are on the recording listening to this back, this can be a little journal prompt for you, or maybe over your lunch break or something, you can integrate this discussion question in with your team. But for those of you who are here live in the webinar, I would invite you to share in the chat box your opinion or your experience on advocacy. What does it mean to you? When you hear that word, what does it mean to you? Or what's your experience and perspective on that? I'll give everyone a minute to share. All right. BB offers offering guidance and support, speaking up when someone may not have a voice. Thanks for sharing. Next, we have sharing with those in power and leadership experiences of gaps in service array. Definitely. Thanks for sharing. Another share to ensure the people we serve have a voice, are heard and understood. Thank you. Anyone else have anything? Great. Getting support from others to help you express your views and wishes. Yes, thank you. Well, thanks everyone for those shares, and do continue to share if you have any further thoughts. Oh, one more that came through. For me, it means using my privilege to ensure that others who may be silenced have a chance to be heard, supporting their voices. Thanks for that. Helping those also advocate for themselves. Definitely. And so you all are already pretty much very familiar with the work of advocacy, or what I'm calling the medicine of advocacy. And we're going to go through some examples of what this means and how does it translate into working with families who experience or are at risk for SED and OUD in the perinatal period. And I did borrow this framework from the field of social work where they talk about systems change or how you can apply social work skills to macro, meso, and micro levels. And so we'll kind of start big at the macro level and talk about what is the medicine of advocacy within society and systems. We've talked at length about this. We really went in depth into it, especially when we're talking about those who are more marginalized, those who come from backgrounds where our culture, language, land really have been under the impacts of colonization for many hundreds of years, many generations of us, that 100% of us as Native people, we come from intergenerational trauma and resilience. And how does that translate into the risks that we face in our communities for increased impacts of substance use? And also the opportunities for recovery and supports in that area. So, if we're going to go into the macro, if we're going into society and we're looking at systems and we're looking to intervene or cause change and be advocates in this space, then of course we're going to start with culture, land, and language reclamation. That's something that is really unique to our community, that if you are in other communities may not be a priority, but hopefully that has really been woven into the whole series and all the discussion that we've been having about how it is that disconnect. We can trace many of the problems in our community back to issues of colonization, land loss, language loss, and culture change. And it is proven both within our lived experiences and within the public health literature that culture reclamation and reconnection to Indigenous cultures is a protective factor for Native people, and especially for Native youth, that the more connected they feel to place and to people, it actually is like a public health intervention that can be employed very strategically in all of the things that we do. And so I know everyone here is really passionate about that as well. But we always want to be advocates that any spaces that we're in, we're uplifting culture and language. We talked last time at length about homelessness and unhoused families and how the systems and society that we live in very much stigmatize and criminalize homelessness, and how the greatest risk factor for being homeless is having been previously homeless. And so it is a cycle that is really difficult to get out of. We did talk a lot about how that can impact families that we're working with in our communities. And if we were thinking big, we would be thinking about drug policy reform. We all know and have lots of information about how that affects the families that we work with at an individual level, very much influenced by what's happening at the national level with drug policies. And while we're at it, we might as well talk about universal basic income and other types of reform that create better economic circumstances for all of our families, especially those who are less equitably compensated for their work and more at risk for intersecting types of marginalizations, which is something that everyone here already knows so much about because we've been talking about it a lot throughout this series, and we can see those direct impacts in the families who are most at risk for substance use disorders and opiate use disorders. We know that tend to come from more socially, economically disadvantaged communities. We know that by far and large, it's our rural communities who are impacted by STD and OUD, and that there are racial and ethnic disparities within the STD and OUD risk populations as well. And so we're thinking big and we're thinking macro. These are some of the things that we might be thinking about. Let me know if there are others that you're thinking about, especially with the really great group that we have here, and all of the different diverse perspectives and influence that everyone here has. And if we were going to go then down into the mezzo, it's not like one is better than the other. It's just we all are plugged into different things. So if we were going to go down into the mezzo level and talk about the medicine of advocacy, what we're talking about here is communities and groups. So just a little bit of a smaller population that we're looking at. A lot of us are kind of primed to be doing this kind of work because many of us work for tribal communities and we actually are able to influence change within tribal communities. So, this is kind of a really cool opportunity for a lot of you. And a lot of you are already doing this kind of advocacy work. And I can definitely acknowledge and honor that in this space. Advocacy at the Metso level consists of recovery mental health services. So, making things available, making them local, making them accessible, having them be rooted in the local language and culture and space of the people, which is something that I would say here in Michigan, we're pretty darn good at and get better at all the time. It includes creating safe ceremonial spaces for people in substance use recovery and ensuring that accessibility exists for people. We shared this quote at the very, very beginning of the series that the medicine people in our community shouldn't be held back by their choices and circumstances, that everyone should always have the opportunity to heal and be accepted back into culture. And that is definitely a community or a group level advocacy that needs to happen. This is something that, in Michigan, there have been a ton of progress on naloxone and Narcan public saturation. That is an intervention, that is a life saving intervention. And so it is definitely encouraging to look around and see that these are available in a lot more public spaces, and we have the education and training to go along with it. There also needs to be group and public awareness of how to use it, as well as the destigmatization of how to use it, and all of the really good work that a lot of you are doing already. Increased access to lactation and birth and postpartum support. So, this is definitely something that I was thinking about when I think about tribes in Michigan and in other states as well. But just thinking about the opportunities that we have to integrate further supports into the tribal healthcare system and to create systems of care that are easily accessible, that are affordable, that are publicly known that these are out there, and so that doula work and postpartum care and birth care and lactation support isn't something that is so highly specialized that only a few people in the community know who's doing the work or where to go and how to access it and what the benefits are. So this is more of like a call to action that tribal communities could actually be doing a lot around this area and making more supports available for perinatal families that are home-based supports. Very congruent and parallel and working in tandem with a lot of the really great home visiting programs and other types of programs that we have. In general, we just need a lot more milk flowing in our communities and a lot more a lot more supports to um, encourage and uplift those who do want to body feed. And then if we're going to get down into the micro level, the medicine of advocacy is reaching individuals and families. And a lot of you are in this space as well. A lot of you are direct service providers, or you are care providers to people in your communities, either through your job or through your role in your community. And so this is really about facilitating improved communication between a client and their care providers. This may include accompanying folks to appointments, and we're going to talk about some examples of all of this and give some case scenarios around these things. Providing educational resources. Don't forget that education is power, knowledge is power, and one of the things that we all can be doing is to work at a community level to be uh, spreading the right information and giving the right vibes out in our community. But also, when clients have questions and they need support and they need advocacy, we're really bolstering their own ability to make good, informed decisions based on their needs and wishes and their circumstances by providing the right, appropriate resources. So we're going to want to know what those resources are within our communities. You are already steps ahead because you're here. A lot of you are really committed to your continuing education and being a lifelong student, but we want those resources to be accessible and reach our community members as well. We really want the knowledge that we've been talking about within this series to become common knowledge once again, so that everyone who wants to access information about our cultural practices in the perinatal period knows what that is, or who to find to ask. We talked a lot about traditional foods and postpartum. What are we doing to integrate that education into our community? How are we making breastfeeding information accessible? What kind of supports and education are out there for those who are in medication MAT programs? I always say it wrong, but MAT, you know what I mean when I say that. That they know their rights and they know that they can breastfeed, and how to be an advocate for themselves in those spaces. So there are a lot of opportunities for us to continue integrating education into our communities and ensure they're reached by those who are most at need. And then one of the more important things that I think we can learn to do, and one of the skills that we can cultivate, is to model for others within the relationships that we have with our clients the ways that people should be treated, the way that we can clearly and effectively communicate with others, and how can we disrupt some of the harming and stigmatizing language that is still being weaponized against our clients, especially those who have a history or a risk of substance use disorders, or those who are in recovery. And we talked a lot about how language can be used as a healing tool or as a weapon. And we talked a lot about how we can disrupt that, especially when we're talking about infants. Some of the ways that we hear our babies being spoken about, or the ways that stigmatizing language is used to describe babies who haven't even been born yet, and the families that were chosen to bring forth these sacred beings. So one of the ways that we can be an advocate without even really trying is by using compassionate and non stigmatizing language in all of our interactions. And even when we're creating resources, when we're at meetings, anytime we have the ability to uplift compassionate and non stigmatizing language, we want to be doing that. And so sometimes it's just a little bit of pushback on the words and language that is used. But I want people to see the way I interact with my clients and community, and I want them to feel like, oh, she does it in such an inspiring way that I could incorporate aspects of that into how I communicate with others. And it is those subtle shifts that do make a big difference for people and in community. And communication is something that's so important and so central to the work that we do. However, we aren't really given a lot of skills as we progress through these phases of life on how to communicate and what are some of the strategies that we might want to be thinking about. And so, when it comes to doing direct service or supporting or educating clients at the individual level, here are some strategies to get better communication or to help facilitate improved communication between a client and their care team. Because remember, they're up against a lot. They're really up against a lot of stigmatization. There could be, there is that compassion there and that desire to care for someone. And then there are just those little sticky things that exist because of the culture that we live in or the society that we live in. So it is helpful if we, as doulas, and I'm kind of coming from that perspective specifically, or a lactation provider perspective, if we are to help our clients, the first thing we really want to do is just slow down for a minute and really help them get clear on their communication goals. Assumptions can be really challenging in these types of settings because everyone's needs and desires are so unique. And I've been humbled by this many, many times. And so I'm only sharing it because I've been there before. But it's helpful for me when I'm working with a client. I want to first know, what are your goals for communication? Is your priority that you just want to be heard and validated? And that's it. Some people really just want to be asked, are you okay? How are you doing? And you may be the first and only person that's ever asked them that in a long time. That enough could like that could be enough for them. Are we taking it another step further? Do we need to do some problem solving with our communication today? Is there some kind of resources that I need to be providing that can help you improve your communication? Are you looking to change the way appointments are going? Are you looking to do something differently in communicating your needs to your care providers or to support people in your space? Are communication goals for the client verbal or are they written? Everyone's a little bit different, or are they visual? I have clients who are not comfortable with having difficult face to face conversations. And so, one way that we can accommodate their needs is to document their communication goals in a different way, either writing them out or texting them out. So everyone's needs are a little bit different, and one size fits all approach to any kind of direct service. We want to just be pushing back on that because we want to honor that everyone's learning style and communication goals are a little bit different. So I start every visit with a client by asking them what are their goals, and I actually have a list that I take them through so that I can help facilitate that for them. A lot of us are problem solvers and we're go-getters, and that's why we're here, and that's what brings us to the work. Sometimes the medicine is just in listening and hearing, and sometimes the skill is just to sit in silence while someone shares what they need to share, and then we can get clear on what those next steps are going to be. Another thing, go ahead. I see someone keeps coming on mute.
That's me, Raeanne. Francesca just offered another definition in the chat for advocacy, so I thought maybe we could do that before we move on to kind of this next section here.
Yeah, can you read that?
Yep. So she talks about helping speak on behalf of others who are not able to do it for themselves, while showing my empathy, interconnectedness without judgment, and always creating a safe space for the families. We all deserve to live a happy, successful life. It is important to have a sense of belonging in our community. It will help others come to know the faith of Creator and that all our ancestors are there watching and guiding us. Advocacy helps save my life. I want to be able to do that for others.
Yeah, that's really beautiful. Thanks for sharing that. Thanks, Amanda, for bringing that forward. All right, so getting clear on communication goals, like the first step, and then the next one is that we can help our clients formulate questions ahead of time. Often our clients feel very nervous or they feel really empowered and really passionate, and they just need a little bit more of a direction, a clear direction on how to facilitate conversations that are impactful and effective and get the job done that they want. And so I will often sit with clients and actually go through, okay, what are three things you need to ask your provider next time you meet with them? And we go back to those communication goals that we already set at the beginning. How can we get you there? What do you need to say? What's your priorities? How are we going to communicate them? And how are we going to document it? Are we going to write it down? Are we doing voice memos? Like, what's your learning style and how can we do this effectively? Are we bringing actual forms in so that you and your care provider can work on them together? Um, are we doing carbon copies? Like you're writing it out and then you're giving them the copy. There's different ways to do it, and clients do have the right to communicate with their care team in the way that matches their learning needs and style. But often it is helpful for them to just sit down and actually think it through and write those questions out. I like to help people simulate conversations, and I utilize scripts a lot. And a lot of you have heard me, talk about my own neurotype and my own learning style and communication needs throughout the series. I definitely bring this into the work that I do and think it's actually really it's kind of a boost to the work that I do because we can practice things ahead of time. I don't like to go in and like just off the cuff state what I need. I have to like really sit down and take what's internal to my brain and make it external. This can be a communication tool that's really powerful for a lot of people. I don't always know like what's the right thing to say in real time, which is why I go back to scripts a lot and I practice things with my kids and I practice them at home. And then when I'm in like, more high stakes environments, I'm like, okay, I know what to say because I've already developed some muscle memory to say this. Our clients can do that too because remember, they're in an unequal power dynamic when they go into any type of care provider space. Even with us as care providers, as community level or like peer to peer care providers, there is that dynamic because we, we are seen to hold more power than them. Whether we do or not remain, that's debatable, but that's the way the obstetrical care systems views our clients. Everyone else is above them, and the clients and their baby are way at the bottom. So we have to know that they're like facing upward. When they have questions, it's not just that they have a question, it's that they have to interact with a power dynamic that can be intimidating, that can feel mistrustful. When we're working with Indigenous populations, we understand the history and the weight of that and the footsteps that we're walking in as public health professionals. I always say this, we're walking in the footsteps of those who actually intended to harm our people. We're still undoing a lot of that. So it's not as simple as just go ahead and ask your questions. It's totally fine. You have a right to do that. Some people may need a little extra encouragement. They need that muscle memory. So I will actually simulate conversations with them and do, like, if you want to call it role playing, that's what it is, where the client can speak to me and I will give them space to say it out loud first before they go into a more high stakes environment. And that gives them a little bit more confidence to be able to do that. And don't be afraid of scripts. I literally write them out. I like practice the right things to say. And clients can do that too, so that they go in and they don't get distracted or they don't get disconnected from their communication goal. They can put it literally right at the top of their paper. This is what I need to talk to you about today, and here are my questions. And I appreciate you listening to me. And while we talk this out, my doula is going to be writing down what we say so that I don't forget, or whatever that script is going to look like. But do not hesitate to utilize whatever tools you have at your disposal to help your clients have that better communication. And then document the visits. This is a form of advocacy that it just works for whatever reason. I've been in lots of appointments with clients where just my presence in the room like creates such a different dynamic for them. They're seen more as an equal member of the team. And it shouldn't be this way, right? Like everything should be centered around them and their needs and what is best for them. But in our current healthcare systems, that just isn't how it is. But having that extra person, and I literally just sit there and I'm nice. Like I'm not, a brat about it. I'm like, I'm just writing stuff down because, my client wants to remember everything we talked about. And that way, if there's any further questions, like we can come back and ask next time or whatever. I just say why I'm there and why I'm writing things down. And often they just kind of like straighten up and just answer the questions that my client has. So it can be really powerful to just have a notebook or a sheet of paper where you're documenting what you talked about. It's also really helpful for communication because, again, everyone's so diverse. Our learning styles are so different. Some people have auditory processing disorders or differences, meaning when they hear information orally, it takes them more time to process what's being said. If you, we all know this person, or maybe you are that person. When someone says something to you and your first word is what, but then like 2 minutes later, you're like, oh yeah, okay. And then you answer the question and someone else is already repeating it, but you're like, yeah, I know what you said. Kids do this a lot. Autistic people do this a lot. There are other types of neurotypes where it's just a little bit of a difference in how things are heard and processed in the brain. If I'm coming at you with information, da 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 da, it's really high stakes information about your medications and your baby's health, and I'm educating you on breastfeeding, and you're doing weight checks and urine checks and blood pressure and all the things that we cram into a 15-minute visit with the midwife or an OB. For someone with an auditory processing disorder or other types of learning difference, that's all going to be extremely overwhelming and it's just going to go away when they walk out the door. And it'd be very easy for them to forget what was said or to get frustrated and shame themselves that they couldn't take it all in. And that is unfortunately the way that most education is provided to pregnant and birthing people. It's done in real time in a really high stakes power dynamic environment. And for those who have those learning differences, documentation is going to be everything. So it's not just that we're doing it to like disrupt the system or, change the way things are done, but it is to literally just help them to understand what was said later on. And we're honoring those who have learning differences and hear things in a different way. Not all of us can take in information and learn it all the first time. And that actually is an Indigenous teaching tool, which is hearing things again and again in order to help them stick. And also taking away one important thing. But if we only have a little bit of time together to do this education and ask all the questions, we're going to need that documentation. So, having some way of doing that for yourself as a care provider, as well as a way of carbon copying that to your clients, is a really important skill. And for those of you who work with clients here in Michigan and Anishinaabe country, we are working on a resource that does just that, where we go through communication goals with our clients in their perinatal health appointments. And we get clear on communication goals. We formulate questions, and then we have space to document the visits. And so we're working on a little handout for you all that you're going to be able to use. And it's going to be free of cost to you that you can just download or print. And you'll be able to actually have those available for the people that you work with, and you can start to integrate those into your care plans with your clients or your patients. So when that's available, we'll definitely make a big announcement and have that be something you can access for free. And I want to share an example of a real life story. And this client that I've worked with, she's just a gem and she really likes to share her story. And so she's given me permission. And, I always go back and give her, that acknowledgement because she found that the experience she had working with a doula and advocating for herself was really powerful for her. And this is a woman who was in long-term recovery from an opiate use disorder, who was on an MAT plan throughout her planned and intended and wanted pregnancy, and who had really turned her life around from being previously incarcerated to being married, being a homeowner, and being someone who was a really active part of her recovery community. And she had really wanted to have a vaginal birth after cesarean. And for those of you who, may or may not be familiar with that, basically there is some difficulties in accessing VBACs in certain community spaces and in certain hospitals. Understand that VBACs are accepted by science and the literature. So the literature and The evidence is in favor of VBACs. However, there are a lot of remaining misinformation and a lot of misunderstanding of VBACs within a lot of birthing settings. And then when you layer in some of the additional risk factors and complications for somebody who's on an MAT program, things can just get like a little more challenging. So you this client had to really advocate for herself in achieving a VBAC rather than going in and them saying right away, well, you just have to have another C-section because that's what you had before. By the way, that is also completely illegal and not no court ever has like there's no law that says once you've had a cesarean, you have to have another. The rights and privacy of a patient follows them through their whole life, even if they're a substance user, even if they're on MAT, even if they have had a C-section, even if they're pregnant, they still always maintain autonomy over themselves. And so, cesarean, you cannot force someone to do it. You literally cannot force someone to have a surgery that they don't want to have. And so, I had this client who was like, well, I'm really nervous about this and I really want to have a VBAC. It's really important to me for all these reasons. And so, can you just like help me with that? And rather than being like, here's what some doulas would do. Some doulas would be like, just stay home as long as you can and just go in and have the baby, when you get really, really close. Other doulas might be like, well, you have to listen to your doctor and you have to do everything they say. And then other doulas would be like, we're going to go in and we're going to turn this place upside down and we're going to like fight the system and we're just going to bring this real negative vibe to it, and it comes from a passionate place and a good-hearted place but isn't really effective. Any of those strategies aren't really the most effective for the person who really needs the support right now. And so I try to take a more middle ground approach and say, okay, I want to support you for the VBAC. And by the way, I have a whole entire binder full of medical literature and evidence to support your decision that goes through all the risks and benefits of a VBAC, all of the risks and benefits of a second cesarean, which, by the way, if you don't know, there are many, and the risk of maternal mortality increases every cesarean that's performed. And we have these special needs for somebody who's an MAT because now we have the introduction of the need for the baby and for the NAS and NOWs that could potentially be needing observation after the baby's born. So we have all these factors here. And rather than saying, just stay home and go in whenever, I'm like, hey, there are actual things that you want to know about that are going to be important to your experience. And knowledge is power. And so I'm not gatekeeping any of this from you, but here's what we'll do. Instead of going in and just saying, this is what we're doing, let's have a conversation with your midwife that she was working with. And if needed, we can bring in this literature and write down some discussion points that say, I don't, the risks of a repeat cesarean is this. I want to avoid these risks. And so here's why I would prefer a VBAC. I would like your support. And here are the things that I have questions on to be successful in achieving this. How can you help me? And we wrote them out and we practiced the conversation ahead of time. So she had that muscle memory in place to ask the questions and could get the internal, external. And we had our little sheet so that I could write down what was being said as they were talking. And automatically it gets the like walls down so that it doesn't feel like the client is fighting with their provider. No one has anything to prove. We're on the same team. We're working together for the same goal, which is a healthy, happy dyad, and that the client's rights to their bodily autonomy are still respected. Now we have this additional risk factors with NAS and NOWs. Let's talk about what that's going to look like after birth. And let's also have an emergency backup plan in case there is another cesarean. Let's face the fear of another cesarean and let's talk about what to do if that has to be an option for you. And let's bring that to your care provider so that they can take you through and ease some of your fears and concerns about that as well. Rather than staying at home and hiding at home, increasing the risk of complications because the risk of complications is a little bit higher. And you do want to know that with a baby who's been exposed in utero to in any kind of medications, even prescribed ones. And so rather than hiding at home and not having the conversation and just going in to have a baby, like surprise VBAC, let's actually just face the facts and let's do it really bravely. And I'm happy to report that everything went really well. Her midwife was extremely receptive to the conversation. It was a conversation that took place over a couple of visits because she had a lot of questions and she really wanted to be very proactive about her care and about her baby's needs and what that would look like. She's a really motivated mom. She had a really motivated and very encouraging and supportive partner. And then she had me, and she did achieve her VBAC, and she did it all unmedicated. She did everything exactly the way that she wanted it. And she did go on to have a long term, full term breastfeeding relationship with her child as well. So, really successful story there that, just shows the power of the skills of advocacy and how to do it rather than just hiding from your fears or not facing them or actually being someone who could actually have a harmful presence or a negative presence in a client's situation. And so, with her permission, I do share that in a lot of my trainings because it's just such a great example of how you can do things really respectfully, but really powerfully and centering the needs of the client. And then lastly, I want to just share some of the ethics of advocacy. One is that we encourage clients to use their own decision making. I always, and clients are like surprised sometimes because they're used to others speaking over them. They are used to people telling them what to do. They're used to decisions being made on their behalf. These are folks who are coming from a history of, potentially engaging with law enforcement, incarceration, um, and our autonomy is already very fragile in settings when we're pregnant, just because of the society that we're in and like the way that we interrogate pregnant people's decisions. So clients are like surprised when, as a doula, they ask me something and they're like, "What should I do about this?" And I'm like, "You make the choice. You figure it out. I'm here to support you on that. I can help you get clear on it and I can help you communicate it. I'm not making choices for you." And they're like surprised. Well, we thought doulas would help us make better choices. Yes, we do, but we're not doing it on your behalf. And it actually is very surprising to them because they're just used to everyone else making choices for them. And so I always say this: you have your own decision making. Let's get clear on your goals and how can I help you communicate them. That's what I'm here for. I come with information too. If you want to know all about VBACs, I have all the paperwork here. If you want to know about breastfeeding, I have all the papers. Like, I'm ready with my own education and I'm ready to just uplift you in whatever way I best can. We don't talk over our clients or speak for them. This is something that I think is a miscommunication about doulas or a misunderstanding about what we do. A lot of people think that a midwife would walk into the room and they would look at the doula and be like, "What does your client want to do?" That's not at all how doulas are supposed to be operating. We're not really like speaking for our clients. We're creating successful environments for them. We're setting them up for success by having these things in place first. Education, information, empowerment, communication, and advocacy. And so I don't really ever have to speak on behalf of my client or talk over them. I don't come in with an agenda to say, "Here's how I think it should be," because this is what I would do. I'm always recentering and uplifting what it is that the client really needs. We don't perform clinical or mental health procedures, so I'm not doing any sorts of screenings. I'm not doing any interpretations of blood pressure readings or anything like that. I'm aware of healthy practices and I can make very straightforward recommendations to my clients for them to come back to their own decision making and help them to feel confident that even if I wasn't there, they would still know what to do and they would know how to communicate. I want them to be able to do it without me. You shouldn't need a doula to give birth. I want you to feel like you can just do it. And so that's always my goal when I'm working with somebody. And I'm familiar with culture. I go with intuition for my own self as a birth worker and with my clients. And I know the research, and that's what we've been talking about throughout this whole session. So I hope a lot of that comes through and that you feel really empowered and have more capacity to bring that kind of work and ethics to what you're doing, which I'm certain you are already doing because all of you are so great. And so that's all I wanted to say. Well, I guess it was a lot. It was a lot. It was almost an hour on advocacy and communication. But like I said, no one ever really sits us down and teaches us how to do it or gives us any skills or strategies to achieve advocacy and communication. And so that was my goal for this session. So, as we wrap up, if you're listening to this on the recording, this can be your homework, or you can integrate this into a staff meeting or however you want to do it. But we are going to do some case studies. And then in conclusion, we'll kind of wrap everything up with some reflections on the impacts of um, the supports that we've been talking about throughout our entire webinar series. And so, just give a lot of gratitude to those of you who've been listening along on the recordings. And I will stop the share, stop the recording, and come back to the group.